Good afternoon, everyone. We'll just wait a few seconds for people to join. So welcome, everyone. Good morning, good afternoon, good evening. A very special welcome to all of you, especially those of you who live far away or are joining at very late or very early times. Thank you so much for being here with us. We have a very important topic today. It's an update on influenza, COVID-19, and other respiratory threats. And we have a number of well-known WHO experts to provide you an overview of the situations, and at the end, answer all your questions. For those of you who are familiar with EPI-WIN, you already know what it stands for. It stands for the WHO Health Emergencies Information Network for Epidemics, and we share information on health emergencies for evidence-informed actions. Today, we have, to welcome you with the welcome remarks, we have Dr. Maria van Kerkhoff, Acting Director for Epidemic and Pandemic Management at WHO. Moderating the session today, the technical session, will be Dr. Wenqing Zhang, who's the head of the Global Respiratory Threats Unit, and of course has been in this area and very well known for years. We have speakers Vanessa Kotza, Technical Officer, Magdi Saman, Technical Officer, Sophie von Dobschutz, who's the team lead for the Global Coronavirus Program, and Iona Giga, Technical Officer for Medical Countermeasures. Then we will have the Q&A session and an overview summary from Wenqing. But before we start, a few housekeeping. As usual, this webinar is being recorded and the recording will be shared with you on our website in the coming days. We do have interpretation today in French and Spanish. So if you go to the bottom of your screen and you see the globe icon and you click there, go to the language that you would like to hear it in. Please, as usual, we'd love to hear from you. Please introduce yourself in the chat. If there's any comments that you'd like to make, please make it in the chat. Share your insights, your experiences. We love to hear from you. But if there is any question you would like to ask from our experts today, please put that in the Q&A box, not in the chat, so that they can keep track of it. And finally, this EPI-WIN is for knowledge exchange. It's to help learn from each other. So let's keep it positive and constructive. All comments should be positive, respectful, and to the topic at hand. Anyone being disrespectful will be removed from this webinar. And with that, before I hand over to Maria, a quick as usual, we'd like to hear from you. So a quick Slido. Slido.com #3008-321. We'd like to know why you've joined today's webinar. What do you find interesting about today's topic? Just in a word or two, it would be great to hear what you're looking for, what you're interested in. Slido.com #3008-321. So we have the first thing, knowledge, global perspective. Preparedness. Okay, some of them is linked to your word. One Health, vaccine programs. Great. About the variant updates, relevance to border health security, patient management, evidence-based data. Yeah, most of your vaccine programs, pandemic preparedness, but it seems for preparedness and for updates and a global perspective. Those seem to be the main ones. I will keep this on, but so continue please with slido.com and put your things there. But in the interest of time, I now invite Dr. Maria van Kerkhoff to please provide the opening remarks. Over to you, Maria.
Thanks very much, Supriya, and good morning, good afternoon, everybody. Good evening to some of you. Thank you so much for joining this EPI-WIN today, specifically focused on giving you updates about influenza, COVID-19, and other respiratory threats. We originally had intended to do a webinar like this as a member state information session, but we thought we would broaden it out a bit more to give more of you an overview of an up-to-date update on the global situation for influenza, for COVID-19 and other respiratory pathogens, to provide you with some updated technical recommendations that have recently been published or updated, some key tools that are available, and the latest WHO strategies for respiratory pandemic preparedness. Before we begin, I do want to remind you all that this year, 2026, marks the 15th anniversary of the PIP framework. There was an EPI-WIN a few weeks ago, or perhaps it was even last week, to highlight this, and I urge you to go back and look at that if you didn't see it. And thanks to all the member states for hosting GISRIS, the Global Influenza Surveillance and Response System. This is the foundation of the PIP framework, and many thanks to the member states, to industry, to academia, to other stakeholders for your enormous support over 15 years for the implementation of this really important framework. Influenza, COVID-19, and other respiratory pathogens continue to pose substantial public health burden worldwide. These viruses are evolving, and the epidemiology of these pathogens is really dynamic. This requires continuous vigilance, strong coordination among member states and partners, and consistent communication. As WHO, the Secretariat for member states, we work with all of you. We work with all member states, all countries, all partners, and communities to ensure that you receive timely, accurate, and evidence-based information that strengthens surveillance, preparedness, and response capacities at all levels. And really important, it's information for action. Prevention and control measures remain essential pillars of the work that we do. Public health and social measures, vaccination, appropriate use of antivirals, improving ventilation, strong infection prevention and control practices, and more continue to be among the most important, effective ways to reduce severe disease and to protect the most vulnerable. Communicating this is the core of what we need to do in ways that are acceptable, in ways that are understandable, and really answer the questions that you have most. Equally important is ensuring communities have clear, accessible, actionable information, effective risk communication, community engagement, support public trust, which we know is very, very difficult to maintain, easy to lose, but difficult to maintain. It's important to encourage protective behaviors and to improve uptake of key public health interventions. By bringing together the latest knowledge, data, and tools, this session aims to help participants translate complex information from many, many different sources into practical, people-centered actions. Strengthening data-driven decision-making will support more coordinated preparedness and response efforts across countries and partners globally. Thank you so much for joining this and for your continued commitment to respiratory pandemic preparedness. I do want to thank all of my teams who are doing incredible work here in headquarters, in our regional offices, in our country offices, our partners in ministries of health, not only in human health, but in the animal sector as well, with our partner agencies, FAO and WOHA and UNEP, and many different local actors and CSOs that are helping us do this work. I look forward to the presentations that you will hear today, to your valuable insights and the discussions that will follow. So let's get on with this, and I pass it over to Wenjing.
Thank you so much, Maria, for set the scene. and also thanks to Supriya for the introduction. I would also like to welcome everybody to this session on the update on influenza, COVID-19 and other respiratory threat delivered through the EPI-WIN platform. We've had a mini EPI-WIN platform, EPI-WIN webinars before, but to us, this is the first time we are using EPI-WIN platform for a targeted audience of policymakers and technical specialists in these areas. So for Q&A, we'll therefore give priority to policy-related questions, although I know we have a broader range of audience connected now. The full update will be shared among staff across the epidemic and the pandemic management department. And actually, I would like to repeat the names of these colleagues again, although Supriya also mentioned. They are Iona Giga, Magdi Saman, Sophie von Dubsches, as well as Vanessa Kosa. During the presentation, please type your questions under the Q&A, not under the chat. And after the presentation, we'll open the floor for questions and discussions. So without further ado, let's kick off the presentation and let's put the slides on. Okay, let's move to the next. Vanessa?
Yeah, sure. Good morning, good afternoon, good evening, everyone. So as my colleagues already mentioned, today's webinar, we are going to provide an update on influenza, SARS-CoV-2, and other respiratory viruses with pandemic and epidemic potential that require continuous surveillance and risk assessment, sustainable preparedness, and coordinated response globally. These respiratory viruses, in fact, circulate and pose a high global disease burden, cause significant morbidity and mortality every year. For instance, WHO estimates that seasonal influenza causes around 1 billion cases annually, including 3 to 5 million severe illnesses and up to 650,000 respiratory deaths. The economic impacts and unintended social and economic consequences of these pathogens are also significant, as demonstrated by previous epidemics and pandemics. The COVID-19 pandemic, for example, led also to widespread disruption in trade, travel, essential health services, and community well-being. Next, please. Now, looking specifically at influenza, the diversity of influenza virus circulating in humans and in animals, and their propensity to evolve and change, and in certain cases also to cross species, requires a global approach to monitor, prevent, and control seasonal epidemics, and to early detect and respond to novel and pandemic influenza, as well as continue monitoring interface between human and animals. For more than 7 decades, the Global Influenza Surveillance and Response System, GIRSIS, has been the foundation for the global influenza surveillance, preparedness, and response, thanks to the enormous commitment of more than 135 member states. Next, please. So if we move now talking about the recent seasonal influenza surveillance data, let's first start with taking a longer view of the GIRSI surveillance since 2020, with the data reported to WHO. This slide here provides a long-term context by comparing influenza and SARS-CoV-2 activities since 2020. The chart shows influenza detection in columns, colored by different types and subtypes, while the blue line shows the percent positivity or sample tested positive for influenza, and the red line shows the percent of sample testing positive for SARS-CoV-2. Following the suppression of seasonal influenza during the early phases of the COVID-19 pandemic, 2020 and 2021, influenza activity gradually returned to seasonal patterns, although with continued variability in timing across regions. If we look at the ongoing influenza season in the Northern Hemisphere countries, influenza activity increased in September 2025 and continued to rise until the end of the year. But detection, as you can see in the chart, started going down since January. Influenza A viruses predominated, specifically the influenza A, H3N2 for this season. In the last Southern Hemisphere season, several countries in the temperate years have also experienced unusually long influenza season, with activity that remain higher than expected for the time of the year. So seasonal influenza viruses, including H3N2, continue to evolve over time. And since August 2025, a rapid increase, in particular in AH3N2 viruses, referred as subclade K viruses, has been observed. Finally, I would also like to mention that the last detection of influenza B Yamagata lineage was reported in March 2020. Next.
So influenza viruses, as my colleague just mentioned, continue to evolve. And for this reason, the seasonal influenza vaccines used every influenza season need to be updated accordingly to ensure vaccines are effective against circulating viruses. So this slide and the following 3 slides will shed some light on the most recent WHO recommendation for seasonal influenza vaccines formulation for use in the next Northern Hemisphere influenza season, which will be 26-27. During this season, influenza A, H3N2 predominated epidemics in most regions and countries, with the majority of genetically characterized viruses belonging to the clade K. It's a genetic group that predominated in most of the regions. So the genetic and antigenic characterization of the clade K viruses showed that they were different and drifted from the H3N2 component of the current vaccine formulation. And antigenically, they are more advanced and they spread widely and dominated other subclades. And evidence from vaccine effectiveness studies further supported a decision during the vaccine meeting in February to include a virus from this subclade into the next Northern Hemisphere influenza season vaccines. Next, please. Among the decisions made is also for the influenza A H1N1, which also circulated during this season in a smaller proportion globally and different proportions in some countries. And of the viruses characterized, another genetic group of this subtype H1N1, 5A2A1, and a subclade D3.1 and D3.11, which shows up on the right side image, predominated as shown. And these viruses were antigenically advanced as well from those in the current season vaccines, but they were similar to those recommended for the upcoming Southern Hemisphere influenza season, which will start this year. Evidence from the vaccine effectiveness studies also supported a decision to include a virus from this subclade into the next Northern Hemisphere influenza season vaccines. Next, please. And in terms of influenza B virus, which co-circulated with influenza A viruses during this Northern Hemisphere season, but they were in much lower proportions in comparison to influenza A. All influenza B viruses characterized during this season, they belonged to the B Victoria lineage and the clade 3A2, but they also further diversified into subclades, other genetic groups, C1 to C5. And of those subclades, the C3 and the C3.1, as shown here on the right side image, were more antigenically advanced than other subclades. And evidence from human serology further supported the antigenic characterization data. Published vaccine effectiveness studies were underpowered to detect effects reliably, but the vaccine effectiveness studies for the Southern Hemisphere were over 50%. Next, please. According to these evidence, which was presented during the vaccine meeting, for vaccines for use in the 2026-2027 Northern Hemisphere influenza season, WHO recommended the listed vaccine strains, and as per the evidence presented in the previous slides. And due to the influenza B Yamagata lineage virus's extinction, WHO stopped recommending the B Yamagata lineage virus component of the vaccines. Next, please.
So this slides displays all human confirmed infection with zoonotic influenza A viruses reported globally to WHO since 2003, stratified by subtypes. Each color represents a different subtype, and you can see that detection occurred over time with a variation of subtypes. The insert on the right highlights the recent couple of years more in detail, showing continuous sporadic cases across multiple subtypes, mainly H5N1 and H9N2. Altogether, this reinforces the importance of sustained surveillance to quickly identify and assess these zoonotic influenza spillovers. Next, please. Now, if you look at this example of avian influenza AH5, you can see that multiple sectorial impact is due to these viruses and requires coordinated approach from different sectors. From an agricultural and food security perspective, cumulative losses due to infection and large-scale preventing culling exceeded 630 million poultry since 2005. The consequences extend far beyond poultry. In 2023, more than 50,000 marine mammals were reported dead, raising concern about viral adaptation mechanism and cross-species transmission dynamics. In terms of global trade, the disruption has also been substantial. Finally, although human infection remain relatively rare, the case fatality rate of approximately 48% for H5N1 underscore the critical need of enhanced surveillance, rapid characterization, and coordinated preparedness across human, animal, environmental systems. Next.
So to mitigate the risk of these viruses or influenza viruses with pandemic potential, or we call them IVPPs, the risk assessment is the first step. And WHO conducts different types of risk assessments. For example, the WHO tool for influenza pandemic risk assessment, or TIPRA. This risk map on the left side shows the TIPRA results, which has a relative risk of the viruses assessed to date. In addition, WHO conducts joint risk assessments together with experts from FAO, WOHA, and the OFLU network, and other academia experts and institutions. And as per the latest risk assessment published last July, the risk from these viruses to global public health is low, and the risk of infection for personnel with occupational exposure is low to moderate. Assessed zoonotic influenza viruses today do not have the ability of sustained human-to-human transmission according to the latest risk assessments. Furthermore, WHO posts a monthly update on the risk associated with zoonotic influenza events. And during the past 5 years, and on average, WHO published 9 monthly and 2 ad hoc zoonotic influenza risk assessments on its website. And since March 2024, WHO changed the frequency of seasonal influenza activity overview and update from bi-weekly to weekly updates, and which now includes also an update on the activity of SARS-CoV-2 and respiratory syncytial virus and other respiratory viruses. Next, please.
So the next slide will give you an overview of the current global coronavirus situation. We are starting with SARS-CoV-2, responsible for the disease COVID-19. And here are a few key messages up front, which I will then illustrate with the following slides. So first of all, our global risk assessment that we publish twice a year. The last one was published in February, so I refer you to that. The link is included here for anything you need to know, and it covers the 6-month period prior to publication. The COVID-19 risk has been assessed to remain moderate with low confidence because we have a huge lack of data, and I'll get to that during my presentation as well. So SARS-CoV-2, as you know, continues to circulate widely and genetically evolve. It continues to co-circulate with other respiratory pathogens like flu, and the first graph shown by Vanessa with the co-circulation over the years has really painted a wonderful picture of how this looks like. We don't see a clear pattern yet, a seasonal or predictable temporal pattern or evolutionary pattern of SARS-CoV-2, and we are, of course, closely monitoring and assessing this continuously. We noticed, unfortunately, a decline in SARS-CoV-2 reporting, and that has several reasons. There is reduced testing and reduced surveillance activities, delays in reporting from countries, or when countries report, they might report incomplete epi data or none at all. And we see a reporting bias towards the high-income countries, which of course has an effect on the outcome of our analysis. So we would really hope for a more representative data reporting from all the WHO regions and as many countries as possible. There's also reduced sequencing and delayed uploading of sequence information into publicly accessible databases. Of course, the latter is important for us and many of our partners to arrive to this information and include it in our risk assessments. In 2026, and we're just at the start, but overall SARS-CoV-2 activity is low at global level. Most countries report a downward trend in test positivity. However, this is a short-term pattern, and you will see in the following graphs that we usually have a low test positivity months in March and April. So this is something that we observed over the years, and we expect this pattern to change and to pick up again in the following months. We also have limited data to estimate the COVID-19 burden of disease, but the data that we have indicates that death rates are indeed similar to influenza for older adults. However, we urge countries to do more burden of disease analysis and ideally using a systematic approach so that we can compare results across countries and regions. Next slide, please. So here you can see the different WHO regions. We have 6 of them, and the test positivity trends. Every line represents a different year. So we have the green line that represents 2024 data, red 2025, and now the blue line, the beginning of 2026. This is data, though, from the post-fake, so post-emergency era. You see in the middle upper graph, and that's representing the Euro region, that countries experience about one major wave, and usually during summer, and then a smaller one in winter. While, for example, in Wipro, which is the graph underneath, so the middle graph in the lower panel, experiences a longer period of increased circulation with at least 2 peaks per year. So again, I want you to look at the period at the beginning. So we're starting from January on the left to December on the right, that we usually have a slightly lower circulation in almost all regions, and that is exactly the pattern that we see right now. Next slide, please. So let's start with the map that you see here. The data shows us a test positivity rate for 28 days and the period until 15 March. This is because we usually have a delay in receiving the information from countries. So this is the most up-to-date data that we have for that period. The Current global SARS-CoV circulation is low, as I mentioned, and only Chile and New Caledonia reported a test positivity rate that is higher than 10%. You can see from the graph below that shows the percentage of samples tested positive for SARS-CoV-2 since 2020, so for the whole period since its emergence, that there has been a continuous decline, and again that the period March-April is usually a sort of low circulating period. We are expecting circulation to increase again. And if you look on the right-hand side, you see the COVID-19 deaths reported to WHO, and this is since January 2023. You will note that the overall number has decreased quite significantly over the years, and most deaths occur in older adults. But interestingly, in South America, we also have data that shows that the age group of 40 to 59 is predominantly affected in the death categories. And this is probably due to comorbidities and malnutrition. Next slide. No, the one before with the globe. Thank you. No. Yeah. So the globe. Next one. Perfect. So this slide is about the hospitalizations. I don't know why it's not coming up properly, but it's unfortunate because this globe actually represents a very good example of this reporting bias I was referring to. If it would hold still, you could see that we have most of hospitalizations reported actually from the Americas and from Europe. There are several regions that haven't reported for over a year now. And of course, this leaves us huge holes on the globe where we just don't know what's going on in terms of hospitalizations and deaths. And then plus in the regions that report, we do have a bias towards high-income countries. So high-income countries are usually the ones that report more frequently. And now we continue with this slide here, which is about the variant circulation. I mentioned that SARS-CoV-2 continues to evolve, and WHO is monitoring and tracking the circulation of variants and assesses their public health risks through our technical advisory group on virus evolution. And then we also have a technical advisory group on the COVID vaccine composition, which also uses this data to make their recommendation for the antigen composition of our vaccines. So you can see in all these graphs, which are just a different representation of the circulation of these variants, that XFG is the variant that is predominant still. However, please note that NB.1.8.1 and BA.3.2 are also on the rise. And all of these have been declared variant under monitoring. So we're really keeping a close eye. We're also tracking other variants under monitoring, like the KB.3.1.1 and LP.8.1. And I'll come back to that, but the latter one is also the newly recommended antigen for the COVID-19 vaccine composition. And you can see that in the bottom graph in turquoise. Next slide, please. Now we switch to MERS-CoV. So this is another coronavirus that has a zoonotic origin and a high pandemic potential. Dromedary camels are the reservoir. Till this date, we do not have specific therapeutics or vaccines licensed, although several candidates are in several states of development. Again, we published a global summary and assessment of risk this January, so please access the link if you want to read more about it. It covers the period from November 2022 to January 2026. And the global public health risk associated with MERS-CoV also has been assessed as moderate. For your information, in the past 2 years, we had 3 healthcare-related clusters. This is one of the risks of MERS that once introduced into a healthcare setting and not identified immediately, and the IPC measures put in place, then there's a risk of further spread in the healthcare setting. So this happened 3 times in the last 2 years. All of them happened in Saudi Arabia. And then also another risk are the traveler cases. Again, we had 1 reported traveling from KSA to Pakistan, and then 2 end of last year from the Arabian Peninsula, where they were exposed to France. And thank God, no secondary cases happened in these instances, because there was good follow-up and IPC measures put in place. And of course, all the contacts during these travels are being followed up and tested as necessary, and none of them came back as positive. So while the risk remains, this is just to show you the risk remains, luckily it didn't result in any epidemic or worse. So zoonotic virus transmission remains an important mode of human infection, because you see all these individual cases that are sporadically reported. They were likely exposed from Dromedae camels or their products. And again, here we see a delayed uploading of sequence information and reduced sequencing as well. Next slide. So someone in our introduction said he or she is looking for fascination. This is fascination for you. It fascinates me. This is actually the global risk of MERS-CoV. The name says Middle East Respiratory Syndrome coronavirus, so you'd think the main risk is in the Middle East, where indeed it's endemically circulating in the countries in dark red. But you see the whole globe is at risk, either through traveler cases, and some of them has caused onwards human-to-human transmission in the past in these countries that are highlighted in blue, but also due to camels actually being the reservoir and being present in many areas of the globe, and especially in Northern Africa. And although we don't have autochthonous human cases reported from Africa, we have evidence from research that, first of all, the virus is circulating in camels in all these countries in the brown shades. And plus, some spillover has happened into human populations, which we could identify through serological studies in humans where antibodies were actually found. Next slide.
Now moving to the RSV surveillance, this slide outlines the current landscape of global RSV surveillance coordinated through the GIRSIS and reported via RespiMart. On the left, the map shows the country contributing RSV data to WHO. At the present, more than 90 countries are providing routine sentinel RSV data, reflecting substantial expansion of the RSV surveillance capacity in recent years. And more recently, over 20 countries are also working on estimation of respiratory RSV burden to generate evidence to inform policy for vaccine introduction. On the right, the time series figure illustrates RSV testing volume and percent positivity reported to FluNet. We see the characteristic strong seasonality patterns of RSV with clear annual peaks. The data set includes approximately 100,000 specimen tested per week, allowing for robust trends analysis. So together, this data demonstrate how leveraging GIRSIS infrastructure enables standardized, high-quality RSV monitoring across diverse settings. Next, please. So now moving more on what tool guidance is available. Here I want to provide to show what guidance we have updated for surveillance. This on the left is the latest updated guidance on integrated sentinel surveillance of influenza, SARS-CoV-2, and other respiratory viruses of epidemic and pandemic potential by the GIRSIS. This guidance advances and updates important elements of the WHO Global Epidemiological Surveillance Standards for influenza and sets out operational considerations for the integrated surveillance of influenza, SARS-CoV-2, and RSV. It supersedes prior pathogen-specific guidance on this area and aligns case definition, sampling, testing, and reporting across viruses. Next, please. So here also, in these slides, we show some additional tools and resources that can support strong respiratory disease management. The PRET on the left provides a platform for national, regional, and global stakeholders to collaborate to strengthen preparedness. Crafting the Mosaic framework supports resilient respiratory virus surveillance. Updated clinical practice guidelines for influenza and living guideline for COVID-19 support standardized patient care. And currently, work is ongoing to update the guideline on infection prevention and control for acute respiratory infections, and also the guideline on the MERS clinical management and diagnostics. Next, please. Now, moving on vaccination, we know that vaccination remains the most effective measure to reduce the clinical severity of influenza. The latest SAGE recommendation is published in the position paper in May 2022. According to this recommendation, all countries are recommended to consider implementing seasonal influenza vaccination programs, especially in priority groups, including healthcare workers, individuals with comorbidities and underlying conditions, older adults, pregnant women. Also, children are considered an important target population. Separately, on H5 in avian influenza, WHO recommends vaccination during interpandemic and emergence periods for individuals with occupational exposure, including laboratory workers, responders of animal outbreaks, people working closely with animals in affected areas, and health workers caring for suspected or confirmed H5 cases. More details on this SAGE recommendation are available in the position paper published in September 2025. Next, please.
And for COVID-19 vaccination, we have two important groups helping WHO to make the recommendations. Again, SAGE, also looking at whom to vaccinate in the context of COVID-19. First of all, the suggestion is for countries to consider their local epidemiology, population characteristics, their access to COVID-19 vaccines, and cost effectiveness, acceptability, and programmatic feasibility. But SAGE came together in March this year and recommend that countries should consider routine COVID-19 vaccination for those groups at highest risk of COVID-19. Because we see that the global burden of severe COVID-19, while declined, is still important for those groups that are of risk for more severe disease. And these are the oldest adults in our population, older adults with comorbidities or severe obesity, immunocompromised, and is suggested at least one dose per year, preferably 2, 6 months apart. And this is because we've seen that there's a waning of protection against severe disease by 6 months after vaccination. Then countries may consider routine COVID-19 vaccination of some additional groups. These are the older adults or adults, adolescents, children with comorbidities or severe obesity, healthcare workers, care providers, more generally pregnant persons, and also in some contexts, healthy children if the epidemiological situation suggests for that. And here it is at least one dose per year, or for those pregnant, per pregnancy, and ideally given in the second trimester. And I included the link here so you can look at the details. There will also be a position paper published this year. Then we have the experts on vaccine composition, the TAC-COVAC, and they decide or make recommendations on what needs to be included in these vaccines. in order to achieve a broadly cross-reactive vaccine-elicited immune response in the context of our continued SARS-CoV-2 evolution. So they look at these circulating variants and their features. The last recommendation was published in December. And as I mentioned before, the LP.8.1 is the recommended vaccine antigen. However, they had previously recommended the JN.1 lineage antigens, and they remain suitable alternatives. And of course, if there are any other approaches that demonstrate broad or robust neutralizing antibody response or efficacy, they can also be considered. And they're actually starting to meet now, building up to the next decision meeting planned for May 2026. They're meeting every 6 months to make these recommendations. Next slide. And here, just some information on the COVID-19 vaccination rates. We collect this information at WHO at global level. Unfortunately, reporting also for this kind of data has dropped substantially over the past 2 years. But we refer countries to all the resources that we've developed in conducting advocacy, addressing misinformation around COVID-19 vaccination, and improving the monitoring and reporting of vaccination coverage. So you see in the table here the number of member states that have a policy for COVID-19 revaccination and boosters. So this is quite a good number still. And when you go to the next column, it's the number of member states reporting COVID-19 vaccination coverage data, and there you can see the drops already. So unfortunately, we have to work and analyze the limited data we receive, and we really hope that countries can improve their monitoring, but also their reporting, so we can have better data and provide better analysis. Below you see access to campaign materials and very nice visuals that countries can use and adapt to their situation and their campaigns. Our coverage manual that has been published recently, and a toolkit with guidance and training and tools around COVID-19 vaccine delivery. Next slide.
So, national actions for strengthening prevention and control document is under development and will be published soon. There is a clear call to action by 2040, to reduce the annual health economic impact of influenza, SARS-CoV-2, and RSV, and prepare for future pandemics through integrated national programs, sustainable funding, and global collaborations. This action plan is based on an integrated approach for prevention and control, which includes 3 main areas: public health social measure, vaccination programs, and the use of antivirals. And it provides specific actions to member states, WHO, and partners that can be taken to achieve these goals. Next, please. Another resource that will be soon available is the updated guideline on public health social measures, PHSM, for mitigating the risk and impact of epidemic and pandemic influenza. This document builds on the guidance that was published in 2019, integrating the evidence generated during the COVID-19 pandemic, and looks at the effectiveness of PHSMs to reduce disease transmission in community settings. It includes a total 21 recommendations across 5 PHSM categories, including personal protection measures, environmental, social, travel-related measures. The guideline will be also complemented by decision navigators, which is currently under development. And this model will support countries to operationalize the PHSM recommendation through risk-based decision-making process. Next, please.
WHO has several initiatives to stay ahead of the curve and prevent or contain outbreaks before they can even develop in epidemics or pandemics. So here, the map on the right shows a global composite risk score for emergence of the 16 pathogens mentioned below, which include SARS-CoV-2, MERS-CoV, and different zoonotic avian influenza subtypes. So these are all pathogens with epidemic and pandemic potential. And the purpose of this map is to identify priorities and strengthen surveillance and diagnostic capacities for both animals and humans, since we're talking about zoonotic pathogens in these areas that are considered of higher risk. And with that, we can enhance our early detection, prevention of, and response to outbreaks of these pathogens. The idea is to improve prevention, preparedness, readiness, and response activities and limit pathogen amplification in human populations. So really limit these outbreaks that could occur in these areas. And we're currently considering additional layers that may be added. This is, of course, subject to funding availability. For example, we could overlay this risk by the diagnostic resources available in different parts of the world to see where our investment would be most needed. We also can add a layer on healthcare system services to see for the high-risk areas if services are actually available where they need to be, or technical and reporting capacities of countries, and many, many more. So this is considered to be one layer in our risk assessments and decision-making. Next.
So, among the available resources for pandemic preparedness, the WHO gears its unity studies, often referred to as unity studies, provide a pandemic preparedness and readiness framework for conducting targeted investigations and studies that are crucial to the risk assessment of novel influenza viruses and other emerging respiratory viruses of epidemic and pandemic potential. A series of template protocols have been developed for use at different stages of a pandemic. These protocols provide a standardized approach for rapid, comparable data generation during the emergency response. To facilitate the implementation of these protocols, a set of operational tools is also available, including ethics toolkit, harmonized statistical analysis plan, and templates for results sharing agreements, which helps ensuring that data generated across countries are timely and comparable. The specific version of these protocols are available, covering influenza, COVID-19, MERS, and the pathogen X. A global network of sites was also launched in 2025, providing an operational platform for rapid mobilization when the new threats emerge. Next, please. So now, in terms of surveillance during an influenza epidemic, an updated guidance is under development and will also be soon available, published. This guidance is meant for national, subnational health authorities and GERSIS laboratories. It aims to provide a standardized approach for surveillance during the transition from seasonal influenza to a pandemic by leveraging existing seasonal systems, the SARI and ALEI, rather than building a new system from scratch. The key shift in this document is the approach in moving from case counting to assessing severity, burden, and impact. The document covers the pre-emergent phase, goes to the emergence of novel virus, community transmission, and stabilized situation, highlighting the importance of action to be guided by surveillance and risk assessment and building on the foundation of resilient communities, multi-sectorial systems, and core capacity for emergence. Next.
So as part of the WHO pandemic preparedness work is to monitor the evolution of zoonotic influenza viruses, avian influenza, animal influenza viruses, and to select and develop candidate vaccine viruses, or CVVs. So these CVVs are developed to be ready for use in a pandemic vaccine when a pandemic erupts from any of these viruses. The new CVVs are selected based on the virus evolution and availability of these viruses to the GERSIS network. The decision to develop new zoonotic CVVs is taken during the WHO influenza vaccine meeting. As of March 2026, over 160 candidate vaccine viruses of these zoonotic influenza viruses of different subtypes like H1, H3, H5, 7, 9, H10 are available for free of charge to laboratories, public and private sector, and from all countries. the movement of these candidate vaccine viruses and sharing within the GISRIS network or with laboratories outside the GISRIS network, whether it's public or private sector entities, is transparently recorded in the WHO Influenza Virus Traceability Mechanism, or IVTM. IVTM is a mechanism to trace the movement of only zoonotic influenza viruses, not seasonal influenza. The bottom graph on this slide shows the number of specimens of shipments of these CVVs that were shipped to within GISRIS network or to laboratories outside the GISRIS network. Next slide, please.
Okay, so the vaccine response at the start of a pandemic is crucial, especially at a time when seasonal influenza epidemics might still be occurring in parts of the world, and when seasonal influenza vaccine cycle is at its final stage. So to ensure the optimal public health outcome from both the epidemics going on at that time and also the pandemic, WHO, after extensive consultations in several years, has finalized an operational document called EPI-WIN, the Pandemic Influenza Vaccine Response Operational Plan. Formally, this document, also called switch from seasonal influenza vaccine production to pandemic vaccine production. And at the moment, this document is in the final stage of publication. This plan facilitates the coordination and the collaboration among WHO, among member states, among manufacturers, and other global players in this area of response. And a part of this PIVROP response actually is being exercised already towards better readiness. Next slide. As mentioned at the very beginning by Maria, this year, 2026, marks the 15th anniversary of Pandemic Influenza Preparedness, or PIP framework, which is a public health access and benefit sharing system, or PABS system, actually. And the PIP framework was adopted by the World Health Assembly in 2011 with the objective to improve pandemic influenza preparedness and response and strengthen the protection against pandemic influenza by improving and strengthening the global influenza surveillance and response system, GISRIS. So in the past 15 years, great achievements have been made, including those included on the screen here. Those benefits are categorized into two areas. On the left side, it is under the SMTA2, capturing for those pandemic response products, including vaccines, diagnostics, antivirals, etc. And on the left side is a second category of the benefits, is called the partnership contribution. It is the cash contributed from entities using GISRIS, its cash contribution to strengthen the global surveillance and the pandemic preparedness. Next.
Yes, so as we saw, WHO secured a number of critical products, and we need to ensure that these can move rapidly, efficiently, and fairly to the populations that need them the most. And to make that possible, we are developing two deeply connected instruments. The first one is the Global Allocation Framework, which sets out in detail how allocation decisions for secure products will be made, basically by whom, on what basis, with what data, and through which mechanism. And the second one is the operational strategy, which looks more broadly at the full sequence of activities across the medical countermeasures response. So not only at allocation, but also the triggers, the financing, the regulatory pathways, logistics, partnerships, and much more. Next slide, please. The access and allocation mechanism and activities need to be underpinned by a set of principles that would guide all related work. And what you see now on the slides are draft principles, and they build on the PIP framework text. And also, on what we learned from past emergency responses. And really, those lessons are clear. An access and allocation mechanism must be built on solidarity, transparency, accountability, equity, and fairness. It must respond to public health needs and risks and be mindful of efficiencies and best practices across all key activities. And this is where complexity lies. Sometimes pandemics force us to navigate tensions between different values that are all legitimate. So to ensure that we can navigate these, we are building a mechanism that is adaptive, it is evidence-based, able to absorb all the data points such as the EPI evidence, the market realities, the regulatory maturity, procurement pathways, country readiness, and really make sure that the decisions are anchored in fairness and equity. Next slide, please. And it was precisely to test all these considerations that we conducted a simulation exercise in September with the WHO colleagues across different levels and with partners. And why do such simulations matter? Because they really expose the difference between considerations and frameworks that look coherent on paper and those that can survive contact with reality and different shocks. So across 2 days, we examined what triggers action across different institutions, what data are needed, when and from whom, how barriers to access emerge, and how location-specific questions intersect with the wider operational response. And there are several themes that emerged. I noticed one of the questions is, what did we learn from the pandemic? What are the best practices? You can also find some in this report here. Some of the themes that are critical pertain to information, which is not a single input, but really a highly dynamic flow. Others around the importance of financing, readiness, coordination, and also recognition that allocation is never a discrete moment. It really is an iterative process of learning, recalibration, and adjustment. Next slide, please. And of course, the value of simulation lies not in the exercise itself, but in what it now changes. And the insights that we gathered from these activities will feed directly into the global allocation framework and the broader operational strategy. And to make sure that we carry forward the most consequential issues, we have now established the cross-cutting working groups across WHO and partners. And we are going to focus now on 3 priority modules. First, around the data systems, because of course allocation can only be as sound as the information that it can count on. Second, modeling and costing to really understand and test how different interventions can combine for the greatest public health impact. And then working on the global allocation platform integration and coordination, because fragmented systems really weaken both speed and legitimacy. And we will continue to keep member states updated on the progress that we are making on this and on other fronts, because we really want to make sure that these secured products are available, they reach the populations that need them the most, and we do this in a timely and equitable manner. Next slide.
So we also recently published our coronavirus disease threat management strategy, and you can find the link here on the slide. This has been an evolution of the kind of strategic documents that we put out not only on COVID-19 since 2020, and you see them listed here, but also earlier on MERS-CoV, because our coronavirus disease threat management strategy is indeed encompassing any coronavirus threat of public health concern. So this is SARS-CoV-2, MERS-CoV, and any other future emerging problematic coronavirus. So in light of bringing this work together also at WHO, we had a restructuring last year, and as a result, a WHO Global COVID-19 and Other Coronaviruses program was put in place at the beginning of 2025, which I'm leading, which brings together our work streams on SARS-CoV-2 and MERS-CoV. And in this strategy, we aligned the strategy with our HAPA framework, which is the important framework that spans collaborative surveillance, community protection, safe and scalable care, medical countermeasures, and coordination as the 5 Cs. And our strategy works across all these 5 Cs and has 4 strategic objectives. And this is, of course, all coming from the lessons learned during the pandemic and from other coronaviruses. And I will remind you not only of MERS-CoV, but also of the first SARS that we have experience with. So all this experience collected has been used to come up with the framing of the strategy. The first objective is to sustain coronavirus disease threat management even beyond the fake phase and emergency phase that countries were facing in the years 2020 to 2022. Then to integrate coronavirus work into the existing programs, for example, the flu and other respiratory pathogen programs that are already existing in countries. The third objective is to enhance the core capabilities along the HAPA framework, and the fourth one to generate, share, and apply the evidence generated, and to make sure that the research gaps that are prioritized by the global community and WHO are being addressed over the years. Next slide. And on a positive note, we set up the Coronavirus Laboratory Network, COVINET. This network was already put in place early on in 2020 to help us with the SARS-CoV-2 pandemic. And we institutionalized it in 2024, and then we further expanded it to 58 labs in 35 countries last year or this year. It's ongoing still. With the objective to help us with the early warning, monitoring, risk assessment, and capacity building. You can see on the map that we have representatives across the globe. We are also, so these are all laboratories, but we are also working on an epidemiological arm in parallel to support with data generation and to help filling some of these knowledge gaps that I mentioned before. Next slide.
Okay, so global influenza strategy, which was introduced in the World Health Assembly in 2020. And this strategy takes a systematic approach to address the problem of influenza, to achieve the goals of reducing the burden of seasonal influenza, minimizing risks of zoonotic influenza, and mitigating the impact of pandemic influenza. This strategy is being implemented and the progress are being tracked. With regards to surveillance, actually, we expect to see that by 2030, we expect to see 100% coverage of the global GIS surveillance. Next slide, please. So influenza has 3 primary forms of public health significance. We all know: seasonal, zoonotic, and pandemic. And over the years, GIS has developed continuous year-round operation to address all 3. With this platform, respiratory syncytial virus was taken on board since 2015, and since March 2020, SARS-CoV-2 has been integrated into this flu platform. So building on the decades of experience, including those from COVID-19 pandemic, GIS continue to be strengthened through collaborative surveillance, engaging specialized bodies in specific areas and on specific needs. So through these ongoing efforts, GIS built for influenza, demonstrated for SARS-CoV-2 and for ISV, is strengthening itself and getting ready for novel respiratory disease X. Next slide, please. So we know that influenza, coronavirus, COVID-19, and other known or emerging respiratory threats continue to affect humanity. This requires coordinated action from all of us, including WHO and member states. So here are some key asks for member states to take forward. First, to strengthen vigilance to the emerging respiratory threats through enhancing public health education, clinician awareness, early signal detection, etc., and advancing IHR core capacity building to ensure timely notification to WHO of those unusual events. Second, to reinforce surveillance at human-animal interface, to expand and strengthen the laboratory detection capacity for avian influenza, swine influenza, and MERS coronavirus in human, build a rapid response capacity, and apply One Health approach cross-field activities. And third, to strengthen integrated surveillance through GISRS for countries without yet a national influenza center of GISRS. You are encouraged to develop such capacity to be recognized as a member into the GISRS, the global system, and maintain sentinel surveillance-based surveillance complemented with the event-based surveillance and other surveillance mechanism to track respiratory threat, and also to develop surveillance-based studies, for example, monitoring the vaccine effectiveness, estimating disease or burden, etc. Next slide, please. Also, to enhance prevention and control of seasonal epidemics, and to promote the seasonal vaccination coverage for those high-risk groups, consider to implement the recent SAGE recommendations on COVID vaccination, and also review and generate evidence to guide national policies for the introduction of RSV vaccines and other preventive products. And to strengthen pandemic preparedness, build systems nationwide through the exercise in the response to the current avian influenza outbreak, and to enhance preparedness through implementation and exercise of the WHO guidance and initiatives. Next slide. So I would like to conclude by acknowledging the tremendous support from member states, which has enabled the significant achievement we have seen so far and those still to come. Let us recognize the 15th anniversary of PIP framework in 2026, and let us acknowledge 75 years of GISRS, actually, which will be due next year, of this great system, and let's continue to build on this momentum together. I would also like to thank my colleagues across the Global Influenza Program, the Global Coronavirus Program, the PIP Secretariat, and Medical Countermeasures in the Department of Epidemic and Pandemic in WHO headquarters for their excellent support in putting the slides together. Okay, that concludes actually our presentation. I know we have actually covered the broad aspect of WHO's work on the front of respiratory threat itself. And I hope our seamless handover among our speakers also worked out. We have actually, maybe we can do a few minutes of Q&A if agreeable to everybody, as we do receive quite a lot of questions. And I would like to ask our panelists to keep the answers as short and to the point. Let's have 2-3 questions, actually Q&A if possible. Okay, so let's take one question about lessons learned from COVID. And I would like to ask Iona to start first and go around our panelists. Certainly, we've learned a lot of lessons from COVID and how they are being reflected in the current preparedness and response. Iona, please.
Thank you very much, Wenjing. Indeed, there have been many lessons learned from the COVID pandemic. I will maybe focus my reflections on the medical countermeasures side. And I think one key consideration is the biggest problem we're trying to solve is the equity gap. And I think we often think of equity as a one-time aspect, but we should think of it as something that needs to be thought through and embedded from across the whole value chain of medical countermeasures. So starting from the research and development efforts all the way until the country delivery. And this is what we're trying to do with the work with the global allocation platform and the operational strategy, to really look across the whole end-to-end continuum and make sure that we put these provisions in place to counteract these potential gaps. And I know the question was also about countries and what countries with limited resources can do in regards to their pandemic plans. And one of the key aspects that we advocate and we look at when we go and do the country missions and provide the technical support is not to call for parallel systems, but to really work with what the country has to strengthen the capabilities and capacities that exist, and to really look through all the scenarios and all the potential aspects that might come into play, so that we put in contingency plans and we make it very clear where the areas of support are needed. So really a very clear analysis and building on what the country has and strengthening these dual use, let's say, capabilities that build on the health system that exists.
Others would want to add? Just a signal. Otherwise, I would also like to add on this, for example, based on the experience learned from COVID-19 pandemic, the public health social measure guidelines actually have been updated. As we've seen, the receptiveness, for example, or mask wearing, etc., in parts of the world, which of course had not been the case before COVID-19 pandemic. And also with regards to engagement mRNA, vaccine producers into the seasonal vaccine production community, etc. So these are all the efforts are ongoing, being learned and integrated into the future pandemic preparedness and response. Maria, you have your hand on. Go ahead.
Yeah, I do. If I may, because I think this question we get so much in terms of what have we learned. I mean, I think the bigger question is what didn't we learn during COVID? And I think, there were many things that we learned during the 2009 flu pandemic. But I think one of the things that we're proud of and we keep working on is that we are a learning organization. We learn, how important preparedness is. I mean, as you've seen through the presentation, we were able to really hit the ground running because of the foundation that we had with flu, we've had with GISRIS, we've had with MERS, we've had with SARS. And this is across the spectrum in terms of detection all the way through R&D. We had guidance that had been developed for another coronavirus that we quickly adapted to SARS-CoV-2. But we also have taken a lot of lessons in terms of increasing production, not only of vaccines, looking at tech transfer, looking at the financial systems to be able to support. We now have a pandemic fund that has already provided $1.2 billion worth of financing to countries for surveillance, for workforce, and we can go on and on. The pandemic agreement is one of the things that is directly coming from COVID, in terms of not only saying we need to do better, but to actually take concrete steps to do so. We have the PIP framework for flu, but we didn't have anything else really set up for other pathogens. And this is something that we've been taking some concrete steps to actually address. And member states are currently actively negotiating this and working really hard to set up what they call the PAB system, the Pathogen Access and Benefit Sharing System. But we've also learned a lot on the One Health side of things. We've learned a lot in the IPC space in terms of what we need to do to protect health workers, to protect people in the community, to improve ventilation, so we can go on and on. And I think this is something that doesn't stop. We haven't finished with COVID yet. We are certainly not finished with flu. We know there will be another flu pandemic. We just don't know when. There may be another coronavirus pandemic. And we need to work with governments to be ready to be agile. So it's a great question. Keep asking us this question. Keep asking us for answers and concrete answers. But you've heard from incredible presenters today. And I will reiterate what Wenjing said at the beginning and at the end. We're nothing without our partners. We're nothing without our member states, without the academic institutions, private sector, academia, civil society, faith-based leaders, youth, many different disciplines. So thank you so much for your support of actually advancing pandemic preparedness for respiratory diseases.
Thank you so much, Maria, for these actually important highlights to that question and also for way forward. I would like to take another question because this question was asked several times in the Q&A. It is about the implementation of the PIP framework and technology transfer. So I will start and then I'll ask Iona also to add on. So the benefit of PIP actually is being captured from the benefits generated from the viruses shared. And that is from the surveillance, from the vaccines, and through the monitoring of surveillance, also the antivirals, the diagnostics, for example, the updated products or diagnostics, etc. So, and of course, another category of benefits are the research academia. If they receive the PIP biological material, they will reach an agreement, SMTA2, with WHO, and that could include the research and R&D, I&D, etc. But it's not really the direct linking of the virus sharing of the PIP framework and technology transfer itself. Instead, there are other initiatives of WHO about developing country capacity building and technology transfer of that. Actually, there's an mRNA technology transfer of WHO as well as other initiatives of that. So this is a point I want to make because it's not an equal to virus sharing PIP and the technology transfer itself here. Iona, would you like to add something on this about the MC?
Yes, thank you so much, Wenjing. I mean, you answered it very comprehensively, so there's not much to add. But just because I looked at the question, I think there was a nuance around the coherence that we're trying to achieve with partners who are also engaged in these projects, that involve technology transfer. So this is what we're trying to achieve with this platform that we're building, really creating the connections between the countries, between the manufacturers that are in certain countries as well sometimes, and all these initiatives. And as you mentioned, one of the flagships of WHO in collaboration with other partners is the HTAP, which has the mRNA transfer program. And one of the recipients of this program is actually engaged in influenza mRNA production. And as you mentioned, also the technology transfer is one potential benefit under the SMTA2s. So there is the mechanism to support this. Thank you.
Okay, so I think we'll take the last question. I would like to engage, for all our panelists to make their comment is about surveillance, where in low resource settings, as well as the testing of human suspected cases in countries with avian influenza circulation, etc. So who would want to start? Magdi, would you start with the testing of avian suspected cases?
Sure. Thank you, Wenxing, and thanks to the question raised. In fact, in many countries where there are outbreaks of avian and animal influenza viruses, the implementation of the One Health initiative, collaborations between the different sectors, the agriculture sector, animal health sector, and the human health sector, is very important in responding and for detecting an early detection of these cases. In fact, I can give an example of in some countries where the outbreak happens in, let's say, backyard poultry, when the agriculture team is informed of such outbreaks, they already communicate with the public health sector, and two teams will go to the location, start testing for humans that came in contact with these sick poultry or dead poultry. And this helps a lot in early detection of these human infections. And of course, it protects lives because early detection means early treatment and survival, as these viruses may have a severe disease outcome. Over.
Thank you, Magdi. Vanessa, do you have anything to add?
Thanks, Wenjing. Not so much to add to what Magdi said, but just to mention that for also countries in low resources settings, we have published these guidelines on integrated surveillance. There are some standards with the minimum number of samples to be tested to have a significant trends and evaluation of their seasons. And the link is available in the presentation. Okay.
Thank you. And I don't know if Sophie, would you also want to say something about surveillance in low resource settings?
Yeah, of course, what is important also in the context of SARS-CoV-2 surveillance or MERS-CoV in those areas affected is to make best use of existing infrastructure and methodologies. So, for example, we mentioned the GISRIS system, which has been put in place in many of the countries. So this can and is being used for SARS-CoV-2 surveillance as well, which is really an important generator of information. And no matter the setting and the resources available, I think what is also important is to collect and to report and share good and comprehensive data, which can be collected. You know, you might have less data in certain settings that you can collect, but make sure it is a comprehensive data. So actually we can make the best use of it and use it for our analysis at country, regional, but also global level.
Thank you very much. I would also like to add that there are questions about isolated settings, islands, etc. One, the first question I would recommend our colleagues in these settings to ask is that for what purposes you are going to set up surveillance, or your surveillance is to serve what purposes. Start from there. And please talk to the WHO country office or regional offices or us. We're very happy actually to help you to prioritize the need using the available resources. So with this, we have to close the discussion sessions here now. I would like to thank all my speakers here, as well as Maria, for staying with us the whole webinar. With this, I hand back to Supriya.
Thank you very much, Wenjing. Huge thanks to Maria and Wenjing for organizing this whole very special EPI-WIN. As she pointed, this is the first one that's actually a briefing for member states. And thanks to all the speakers, Sophie, Vanessa, Magdi, Iona. You can see from the emojis and from all the comments that it's been really very well received. So thank you very much. I'd also like to thank everyone who's worked in the background to make this webinar happen. Michael and Armoral, Yoyi, Josine, we have the whole virtual meetings team, our IT support, and all our interpreters. Thank you very much. There's a lot of coordination that came together to make this very special. And especially to our participants, we had more than 1,200 people online at one time today. So very, very happy to see this great interest. As you know, those who are familiar with EPI-WIN will know, we have one final request for you, which is what is your most important takeaway from today? This is something that we share on every EPI-WIN at the end to find out what is important for you and how useful it has been for you. So very quickly, because I know we're over time and you may be busy, but we'd love to hear from you. Please do share with us what are the most important learnings for you from today's webinar. Again, slido.com, hashtag 3008321. Strong surveillance, global perspective, cooperation. There's still more than 600 of you online, so it would be great to see. Answered all my curiosity. Fantastic. So the two most important learnings is the guidance support and the global perspectives, it seems, and the cooperation. Just wait for a few more responses, as it would be nice to have at least 100 people respond. I know it's late, but it would be great to hear from you. So there's vaccine recommendation, ongoing planning, IMC, MNET, current updates. That's great. Thank you very much. Thank you very much. And we hope to see you again on the 15th of April for the next EPI-WIN webinar, which is on the chat. The link is on the chat. These are the upcoming EPI-WIN webinars for April. On the 15th, we will be talking about cholera in humanitarian situations as part of our Community Protection for Cholera series, where we will share practical strategies and operational lessons. Then on the 29th and 30th of April, as part of operationalizing One Health, as part of the One Health Festival series, we will be focusing on operationalizing One Health, from IHR amendments to the pandemic agreements. All of this is on the EPI-WIN website, and we look forward to seeing you then. Thank you very much. And once again, a huge thanks to all our speakers, particularly to Maria and Wenqing. Thank you. Bye-bye.